I'm Patricia Copat. I'm from Belo Horizonte, Brazil. And first, I would like to thank Latin America and Miss Fan Imaging Symposium 2021, co-chair Dr. Roberto and Dr. Lihteh Wu for the kind invitation. And today I will present a case related to the topic mapping the structure-function relationship in glaucoma. I have this disclosure of interest, Heidelberg Engineering. In our case, so a patient, female, 72 years old, considered as glaucoma suspect about 5 years ago, using brimonidine twice daily with a high blood pressure in use of phenylapril, and she had a moderate glaucoma. The visual acuity is normal in both eyes. In the biomicroscopy, she had redness, follicles in the inferior and superior tarsal conjunctiva, moderately shallow anterior chamber, Van Herrick 2, and a nuclear sclerosis. The intraocular pressure, 14 in both eyes at 11 a.m. The fundus photo, so we have in the right eye a 0.6 vertical and a 0.5 horizontal cupping with an inferior notch and a hemorrhage. And in the left eye, we have a 0.6 vertical with a 0.5 horizontal cupping and some drusen in the posterior pole. So the diagnosis is an open-angle glaucoma in brimonidine-induced follicular conjunctivitis, and we did a washout of brimonidine and returning 4 weeks for glaucoma workup. The central corneal thickness in the right eye, 517, and the left eye, 522. The gonioscopy and narrow angles, Sheffer grade 2, and the IOP daily curve at 9 and 10:30 a.m. and 2 p.m. The right eye 20, 19, and 18, and the left eye 19, 18, and 19 without the medication. So her visual field, the 24-2, we can see that the GHT and the PSD are within normal limits. And in the OCT, we can indicate a local thinning in the temporal inferior region of the retinal nerve fiber layer and in the MRW in the right eye. And the special pattern of glaucomatous retinal nerve fiber layer loss, as we already well know, is in the temporal superior and the inferior temporal zone, as we call the superior vulnerability zone and the inferior vulnerability zone. But which regions of the macula are the most vulnerable to glaucomatous disease damage? So just remember, the macula has the highest density of retinal ganglion cells, is in the central 8 degrees, has less than 2% of the retinal surface, over 30% of all ganglion cells, and 60% of the visual cortex. This is a current segmentation of the retinal layers with histological occurrence that allow us the measurements of the layers of a particular interest of the study of glaucomatous damage of the macula. So here we have the retinal nerve fiber layer with the axons of the ganglion cells, the ganglion cell layers with the soma, and the dendrites with in the inner plexiform layer. So the most vulnerable zone inside the macula send their axons to the inferior quadrant. The less vulnerable zone inside the macula send their axons to the temporal quadrant of the disc, and the most vulnerable zone outside the macula send their axons to the superior and to the inferior quadrant of the disc. So the most vulnerable zone inside the macula send their axons to the inferior quadrant of the disc, and overlaps the inferior vulnerability zone, and this we call the macular vulnerability zone. And this is where early glaucoma is often present, and this is why it's so important to search for the macula when we have some damage here. So with the discrimination power of the spectralis model premium edition deviation maps, we can visualize some structural loss and a comparison of the thickness measurements with the reference database enhance their diagnostic values. So our patient showed thinning of macular ganglion cells in the temporal inferior quadrant sector of the right eye and corresponding to the macular vulnerability zone. So can we relate local macular ganglion cell layer thickness to local functional loss? So here we have the Hood model for the 24-2 points superposed and spaced every 6 degrees. And this is the macular model for the 10-2 visual field with the points superposed, spaced every 2 degrees. And the superior macula corresponds to the inferior visual field, and the inferior macula corresponds to the superior visual field. So again, the fundus view with the 24-2 points superposed, showing that almost no points test areas of common damage and cannot predict a structural function relationship, while a great number of the 10-2 points in the macula improves the prediction of the structural function relationship in those effects centered primarily in the macular vulnerability zone. So again, in the 24-2 of our patient, we can see despite the GHT and the PSD within normal limits, we can see some points of sensitivity less than 5% in the upper side of the field. However, the paracentral visual field defect in the right eye, in our case, is evident using the 10-2, and she has a deep defect. So the Hood glaucoma report, available on Spectralis Model Premium Edition, incorporates the visual field points overlaid by retinal nerve fiber layer and the ganglion cell layer thickness and deviation maps. And in our patient, it clearly shows the structure function relationship between the inferior macular vulnerability zone and the upper visual field loss in the 10-2 of the right eye. And notice that can miss the macular damage in the 24-2. So the spatial agreement between the 10-2 visual field and the OCT thickness map is really impressive. So the diagnosis is an open angle glaucoma with paracentral visual field defect seen in the upper 10-2 associated with peripapillary retinal nerve fiber layer and macular ganglion cell layer thinning in the temporal inferior region of the right eye. And we fixed a combination of bimatocross and timolol. And currently, the patient is stable by visual field and OCT during the follow-up, and the IOP is between 10 and 12. So I would like to acknowledge my team from Hospital São Geraldo and Universidade Federal de Minas Gerais, and especially to my advisor, Dr. Alberto Diniz, for all the support and this great opportunity. So thank you.